Thank you very much for this opportunity. I'm Arvind Dasari. I'm a professor in the Department of GI Medical Oncology at MD Anderson Cancer Center in Houston. So this trial was a phase 2 trial of TAS-102 in patients with colorectal cancer who had completed all curative intent therapy. So stages 2 through 4 colorectal cancer patients who underwent surgery or other curative intention therapies, received all the appropriate systemic neoadjuvant and or adjuvant therapies, and were undergoing surveillance. During surveillance, they were noted to have MRD, or minimal residual disease, as defined by a ctDNA test using Signatera. The trial was initiated based on the observation that these patients who are MRD positive during surveillance will almost certainly develop a recurrence without further treatment. So that's almost 100%. The second observation that also led to this trial is that there's a lead time between patients turning MRD positive, that is having detectable ctDNA, and actually developing evidence of recurrence on scans. That lead time is typically about 6 to 9 months. And the hope and the hypothesis was that by doing treatments in this intervening period, we could perhaps prevent those recurrences from happening and cure these patients. The reason we chose TAS-102 for this trial is because it is a drug that has already been approved for the treatment of colorectal cancer patients whose cancer had stopped responding to other chemotherapy drugs. And that is what we would be seeing in the setting, because whatever minimal residual disease there is has been refractory to the adjuvant chemotherapy or the neoadjuvant chemotherapy that these patients receive. Secondly, TAS-102 is an oral drug, easily administered, with a very safe profile in terms of adverse effects. So it would be logistically also easy to administer for these patients who've already been through many months of treatment through surgery, radiation, chemotherapy, and other things. And TAS-102 would help make it easy for them to be on further therapy. So these were the kind of the some rationale, background behind doing this trial and behind choosing TAS-102. Yeah, that's a great question. Maybe I'll start by going into a few more details about the study design and the results. So the current trial, which by the way was published in JCO Precision Oncology just a few weeks ago, was a single-arm, single-institution phase 2 trial. 15 patients with resected colorectal cancer were enrolled who had ctDNA-defined minimal residual disease after all curative intent therapy was completed. These patients received 6 months of therapy with TAS-102 at the standard dose and standard schedule. Patients were monitored for recurrence every 3 months with ctDNA and cross-sectional imaging. What we found was that about half of the patients had ctDNA clearance at the 3-month mark. Only about a third of approximately a third of the patients had ctDNA clearance at 6 months. ctDNA clearance at 6 months was the primary endpoint for this trial, with the hypothesis that ctDNA clearance is required but not sufficient for curing these patients. So that is, if we're not even seeing ctDNA clearance, then it's unlikely that this drug would be effective. So as I pointed out, about a third of the patients had ctDNA clearance at 6 months. And that's a substantial number, considering that these are patients um, whose cancer had proven refractory to the standard of care adjuvant therapies. Now, the question is the ctDNA clearance durable in that over time, would the cancer come back after stopping therapy? And indeed, that is what we noted in this trial, in that the vast majority of these patients did have a recurrence of their cancer come back over time. The median disease-free survival for these patients without recurrence in this trial was 9.4 months. So what's the takeaway from all this? It is that TAS-102 was likely delaying recurrences, but not necessarily curing these patients of the recurrence. And that's a great question that we're all trying to answer. TAS-102 is a cytostatic drug, and that perhaps could have resulted in the observation that we noted, and that it was delaying recurrences but not necessarily preventing them. In fact, TAS-102 was also evaluated in a larger randomized trial, the ALTAIR trial, enrolling about 250 patients to TAS-102 for 6 months, similar to what was done in the current trial. And the patient population was also similar, stages 2 through 4 colorectal cancer. And the ALTAIR trial also had a placebo control arm. And what they noted was that in the entire patient population, there was really no difference in the median disease-free survival, which was the primary endpoint of the trial, between treatment with TAS-102 versus placebo. However, in a subgroup of patients who had stage 4 cancer to begin with, before undergoing curative intent treatment, there was a statistically significant improvement in the median disease-free survival. Of note and of great interest is that 80% of the patients in our trial also had stage 4 colon cancer. So these results were validated in the larger ALTAIR trial. And also, I would dare say that this concept of really looking at small cohorts of patients to get a quick signal of go, no go was also validated by the ALTAIR trial. Likely what we would need to do for this model to succeed would be to evaluate other drugs that would have more efficacy. For instance, there's a lot of excitement and buzz around immunotherapy currently, and how immunotherapy may be more effective when the disease burden is low or even minimal. And that's perhaps a great setting in this situation to use and leverage. There are a lot of trials being designed with immunotherapy, be it vaccines, be it checkpoint inhibitors, be it cellular therapies in the setting. And hopefully some of these trials will pan out and help improve outcomes for our patients. I would say that it would be helpful to consider enrolling these patients onto clinical trials. Currently, the NCCN guidelines do not advocate for using ctDNA towards making any treatment decisions, but they do acknowledge that ctDNA has very strong prognostic implications. Um, and that's been proven over and over again that ctDNA is a very, very powerful biomarker. What we're missing before we can truly implement ctDNA into our clinical practice is that clinical utility piece. How do we use this information to improve outcomes for our patients? So what I would say is that we should enroll patients who are ctDNA or MRD positive onto ongoing clinical trials. And there are clinical trials being designed across the country at multiple centers for these patients. And these trials are listed in a website, crcmrd.com, that would have all these trials um, listed and in a way that is easy for providers and patients to understand and digest and process. So that would be my uh, plug, if I may say, to uh, consider contributing towards the body of knowledge by enrolling patients onto clinical trials. That's a great question and something that we've asked ourselves as well about what the next step should be for TAS-102 combination therapies. We've, in fact, amended the protocol to look at the combination of TAS-102 plus celecoxib. And this arm should be enrolling soon in the next few weeks. Patients with ctDNA-defined MRD would be treated with TAS-102 plus celecoxib for 6 months, and celecoxib can be continued beyond the 6 months for an additional 6 months as appropriate. This was built based on the observation from a reanalysis of the CALGB 80702 trial. As you may recall, CALGB 80702 was part of the IDEA consortium, and these were clinical trials across the globe uh, that all asked the same question about whether 3 months of adjuvant chemotherapy was non-inferior to 6 months of adjuvant chemotherapy. The CALGB trial, in addition, asked a second question as to whether the addition of celecoxib to adjuvant chemotherapy would further improve outcomes. In the initial analysis in all patients, the addition of celecoxib really did not have any impact on the risk of recurrence. However, more recently, the team went back and looked at patients who were ctDNA positive and looked at the impact of celecoxib in those patients. And what they found was that in patients who are ctDNA positive, the addition of celecoxib to adjuvant chemotherapy significantly improved the risk of recurrence with a hazard ratio of 0.55. So that's really compelling data. But this was a post hoc analysis of this trial. So in the current effort, we're trying to validate this observation prospectively in patients who are ctDNA positive. So one of the things that I would like to highlight is that in the current trial, we only enrolled 15 patients. But what we also did was that we went back and identified 30 patients who were comparable to the 15 patients who were enrolled. So it was a historical controlled match to the key prognostic factors. And we looked at the outcomes of these 15 patients who were treated with TAS-102 versus these 30 patients who we identified who were on observation. So in a sense, creating um, a control arm from historical data. And what we found was that this comparison was very, very similar to what the data showed from the large randomized ALTAIR trial of 250 patients. The reason I bring this up is because it is important to have these large historical controls so that we can better do these trials. For instance, if you're doing these 15 to 20 patients, if you had a good historical control, you can further strengthen the observations by comparing to a placebo arm. The second thing is when we're actually doing larger randomized trials, it would be hard to convince patients and providers to enroll onto a placebo-controlled arm, controlled trial, knowing fully well that without treatment, most of these patients would recur. So that's one area that we're working on to really develop these robust data sets of historical controls that we could use for future uh, trials to develop these control arms. And we're using data from our institution. We have the INTERCEPT program where we have over 4,000 patients with colorectal cancer, for colorectal cancer being monitored with ctDNA. And we're also wanting to extend this further and would love to perhaps include data sets from other trials and other institutions as well. So that's one area of research. The second area of research would be the fact that TAS-102 and TAS-102 plus celecoxib is very much still the first step. I think there's a lot of work to be done in this space where we need to test a lot of drugs to identify the ones that would work the best. So we are developing a portfolio of clinical trials with the same approach where we test about 15 to 30 patients quickly with novel drugs to see if there's a signal of activity or not compared to historical controls before moving them on to subsequent larger trials. We have, in fact, identified a KRAS vaccine that hopefully will start larger trials in the future. So these two, I would say, are the two main areas of focus that we're doing currently. In addition, with all the data that we've collected on the 4,000 patients, we're also going back and asking other questions. For instance, are there clues that we can identify um, in terms of which patients may best benefit from adjuvant therapy, which patients are the highest risk of recurrence, where those recurrences might be, what therapy should we use in those patients? And these questions are being answered by analyzing uh, molecular data, clinical data, and radiographic data, so putting all that together. Just would like to reiterate the impact that minimal residual disease and ctDNA has already had in taking care of patients with colorectal cancer. I would advocate that this be used more in clinical practice and that we enroll patients onto clinical trials to try and answer all the key unanswered questions and improve outcomes for our patients.